Imagine that there's a solid food sticking in your throat or chest and you are trying to initiate a swallow but you are unable to do so. This is what the feeling of patient which is suffering from dysphagia. Now let us watch a video of an interview with a dysphagia patient.
My swallowing problem started about a little over 2 years ago.
Richard Kennedy has dysphagia, a swallowing disorder usually caused by muscle or nerve damage.
Over the age of 60, half of all people will experience some kind of difficulty swallowing, so it really is an issue that we should all care about and be aware of.
Oh, I'm feeling great.
All right, you ready to do a little bit of exercise?
Yes.
Okay.
Like anyone would be, it really affected him not being able to eat or drink. He would tell me stories about, oh, I used to go with my dad to the ballpark and eat hot dogs and I wish I could have a hot dog. Or, you know, my mom made the best hamburgers and I wish I could have a hamburger. And you hurt for them.
Okay.
My throat was
You got all 3 coins.
eligible for real water. Just swallowing real water today. It's wonderful.
To see him progress from not having anything to the point he is now where he can have anything he wants to eat or drink, it's really a wonderful thing. And he's just thrilled with it. He's come out of his shell and he's just loving life.
In Greek word, dysphagia, dys means difficulty, phagia means swallowing, so it is difficulty in swallowing. Dysphagia is defined by swallowing disorder characterized by difficulty in oral preparation for the swallow or in moving the material from the mouth to the stomach. Dysphagia is also defined as feeding and swallowing disorder, include difficulty with any step of the feeding process from accepting the foods and liquids into the mouth to the entry of food into the stomach and intestine. Normal people swallow 8 to 10 times in a minute and 10,000 times in a day. Normal physiology of swallowing process can be divided into 3 phases, which are oral phase, pharyngeal phase, and esophageal phase. During the oral phase is where you put the food into the mouth, you chew and mix the food with the saliva. It is gathered into the bolus in tongue and get ready to propel into the throat. Next is pharyngeal phase, where your soft palate closes off the nose and your epiglottis will close off the airway. The food and liquid will then propel into the esophagus. In the esophageal phase, there is a series of muscles relaxing and tightening the esophagus, which will propel the food towards the stomach. Now let's watch a video about pathophysiology and diagnosis of dysphagia.
Oropharyngeal dysphagia is generally going to be neuro causes. That is, it's from the brain. You can have lesions of the vagus nerve, right, or in the spinal column. So you're going to see things like demyelinating diseases like multiple sclerosis, transverse myelitis, or strokes. Something that's taken out the cortex or the pathway between cortex and the mouth. It's generally not going to be an obstructive lesion. Now it can be. Can you have a tumor that causes oropharyngeal dysphagia? Absolutely. Right? Cancer can do whatever it wants. But generally what I want you to feel, what I want you to see, is that if someone has trouble initiating swallowing, it's probably going to be a neuro cause. Of course, you're going to get to oropharyngeal dysphagia if there is coughing on initiation of swallow, if there's gagging on initiation of swallow, or if there's anything on the initiation of swallow. And it's initiation of swallow because that first part requires coordination of a lot of muscles. The tongue, the posterior oropharynx, the upper esophageal sphincter, everything's got to move together. If everything doesn't move at the same time, that food bolus is not directed directly into the esophagus. Food sticking above the clavicle, cough, or gagging on initiation of swallow, oropharyngeal. On the other hand, if there's no history of neurologic disease, there's no cough, no gagging on initiation of swallow, where the food gets stuck and it's below the clavicle, that's esophageal dysphagia. And esophageal dysphagia can be further broken down into motility and mechanical. Mechanical means obstruction. Something is in the lumen that should not be. That's an obstructive process. Motility is a functional issue. That is, nothing's wrong with the esophagus structure, but the contractions that get the food into the stomach don't work right. The way you can assess that is by what they have dysphagia for. If someone has dysphagia for food and liquid that was not progressive, that's a motility problem. It's not the caliber of the food, it's not the size of the food bolus, it's just anything that gets in their esophagus won't go in their stomach. On the other hand, mechanical dysphagia is going to be progressive. First to large caliber foods, then to liquids. And this represents that obstruction getting bigger. Eventually, it gets to even liquids which can't pass. It starts off as a small obstruction, so big pieces of steak get stuck, but most food goes down no problem. As the obstruction grows into the lumen and there's less and less space to get food into the stomach, the less likely food is to pass, including liquid. So that progressive symptoms, that progression makes it more likely mechanical.
Next, I will move into the factors leading to dysphagia. Bear in mind that problems can occur at any stage of the normal swallowing process as food and liquid move from the mouth down the back of the throat through the esophagus and into the stomach. The first factors that can lead to dysphagia is the neurological deficit. In neurological deficit, the sensory motor impairment of the oral and pharyngeal phase of swallowing can cause dysphagia. The symptoms include difficulty in managing secretion as well as choke or cough while feeding. As for the aging, the obvious changes that occur, such as missing teeth or shifting tooth position, can affect how we prepare food to be swallowed. The elasticity of esophagus to relax and contract also decreases with increasing age. Surgical and esophagitis. As for the esophagitis, the inflammation can cause pain when swallowing. Next is esophageal spasm. Esophageal spasm is actually a painful contraction within the muscular tube connecting the mouth and the stomach, which can prevent food and liquid from traveling through the esophagus. Diverticula is pouches that form at the wall of the esophagus. Some diverticula collect food, which can lead to dysphagia and feeling a need to clear the throat. As food collects in the pocket, it promotes bacteria in the esophagus, which commonly lead to bad breath. As for the head and neck cancer, which include the cancer itself and its treatment, the type and severity of dysphagia will depend upon the size and location of the original tumor, the structure involved, and the treatment modality used for cure. The gastroesophageal reflux disease is the damage to the esophageal tissue from the stomach acid backing up into the esophagus, which lead to spasm or scarring and narrowing of the lower esophagus. Last but not least is the trauma or burns. Severe burns to the face and neck region have many physical compromises that contribute to dysphagia, including skin retraction and positioning problems.
As for the signs and symptoms of dysphagia, we can check the patient if they might have recurring chest infections or pneumonia. This is because they cannot swallow properly, and thus drinks and liquids could get into their lungs and cause infections. Other signs and symptoms include such as sensation of food stuck in the throat, chest or behind the breastbone, complaints of swallowing difficulty, food stuck in mouth, and also trouble in completing a meal. We can also check if the patient have a wet voice or regurgitation, as this also shows the signs and symptoms of dysphagia. If the patient have cough, choking when eating or drinking, this is might due to their inability to swallow properly, which is what dysphagia is. Last but not least, we can also see if the patient have pain when swallowing or drooling. For the consequences of dysphagia, it might be that, as we mentioned before, the patient have pneumonia or recurring chest infection. This is the consequences of having dysphagia. They might also have a reduced quality of life because, first of all, they might get malnutrition because they cannot swallowing properly. Thus, it makes them difficult to eat and also drink, which leads to malnutrition. Having this problem also negatively impact the social life because they cannot eat fast, and thus they might become a burden to their friends, and thus will negatively impact the social life. And also from the malnutrition, this is also because due to their weight loss, because they cannot eat and drink properly. Also due to the malnutrition is the increased duration of hospital stay, and lastly, they can also suffer from dehydration and also depression. Now let us watch the food consistency demo for dysphagia patient.
Disclaimer, we did not advocate this for commercial purpose, as in that this is more convenient to us because you can get it from the pharmacy and the bag off you can have it. So it costs around, I think it was 50 ringgit. So it costs around 50 ringgit. So interesting thing about this stick is that, as mentioned here, it has a neutral flavor with ultra smooth mouthfeel. It does not alter flavor of formulas, beverages, and foods. And it's also very stable, even in microwave settings and freeze or stable. So first we will have a look at the nectar-like consistencies. As Ching is holding, Ching is holding. So this is the nectar-like consistencies. So the recommended usage of this powder thickener, as mentioned, for clear liquid, we use clear liquid with 100 ml of volume. So it requires 1 scoop of this powder to get a nectar-like consistency. So the next consistency is honey nut, which required 1.5 scoop of this product. 1.5 scoop of this product. And lastly, we have the pudding or spoon thick consistency, which required two scoops of this product. So as you can see, can you show them the other side of the spoon? As you can see, it starts there. It starts there, but it can fall off. More likely, it will start there. And then we move on to the foods. We've moved on to the foods. So we prepared rice, 3 different consistency of rice. Okay, so the first one is the normal consistency of rice. Can you show it? Okay. Yes. So it's basically just normal cooked rice. Okay. So the second one is the porridge-like rice. So we have prepared it this afternoon. So since the time has passed, it becomes quite kembang. Okay, kembang, whatever the word is. And lastly, we have this kind of consistency. This one is very pureed. Pureed rice. It's plain. It's like mashed potato, but more thicker. Very thick. Yes. An interesting thing to know about this product is that 1 scoop equals to 15.5 kilocal. So if we want to include this product in our patient's medical need, we have to make sure that we include all the calories, because, for example, the second consistency for just 100 ml is 2 scoops, which already equals to 30 calories. Okay, and then there's only the carbohydrate compound, which is 4 grams.
This is our brochure, we can check it. And this is also our references. That's all from us. Thank you.